Okay, some studies that have been done. There are many studies that demonstrate this, but I'm going to try to convince you why you should use ultrasound to do your central lines. So this is like an example of a study. It increased the first attempt success rate by 57%. It reduced the number of puncture attempts. It reduced the overall mechanical complications by 71%. It reduced inadvertent arterial puncture by 72%. It reduced hematoma formation by 73%. And it reduced the time to successful cannulation by 30 seconds. So the argument that ultrasound takes longer is not true. Ultrasound makes it easier and it makes it less complications for your patient. It is so much better. So we all need to use ultrasound, okay? Okay. So your equipment that you need the ultrasound, of course. You need a sterile probe cover, which I don't think currently in the emergency department we have sterile probe covers for the ultrasound, but I'm not sure. Do you know?
We have several ones.
You do?
Yeah.
Okay,
just
perfect.
5 to 6
Okay.
covers
Where is it in the ER?
It's in, yeah.
Will you tell Di where it is? Because I asked him yesterday and
we
he said...
we have borrowed from the ICU maybe several months ago, but I know whether it is there anymore.
Okay, Di.
We don't use it.
I know you don't use it, but you have to use it now.
Right.
Okay.
Most of them use condom. When you they use condom for that.
Yeah, that works. Just something.
Yeah.
And if it's an emergency and you're not using sterile technique anyways, that's okay. Like if you have to emergently put a line in without sterile technique, you can still use ultrasound. Okay? Okay. All right, and then you need sterile gel, and then of course your normal equipment, your central line kit, your drape, sterile gloves. Now we talk about which probe to choose, and the best probe is this one here. So this is going to have high image quality, and it has low tissue depth, so it's for like it's more superficial structures. But this is the one that you want to choose for vascular access, venous access, and ocular ultrasound. On this machine here, we don't have this as an option, so we're going to be practicing using the curvilinear probe. If you don't have a vascular probe, choose curvilinear, okay, over cardiac. Cool. All right, so now we talk about ultrasound probe positioning. So again, you want the transverse view initially for placement, and you're going to put the probe marker to your left. That's very important because most ultrasounds, we talk about doing it to the patient's right. But if you think about when you're doing a central line, you're moving, sometimes you're standing above their head when you're doing jugular, and then you're going to move down to their femoral, and then again, it still needs to be to your left.
Another way to think about that is just match up that left is left. So if you're moving your probe to the left, you should see on the screen that things are moving in the same direction. You don't want them flipped, it's going to confuse you.
Yeah. Because then you can imagine, like, if you puncture your needle, like, yeah, you'll have your probe marker here. And you'll be, anyways. Here's your jugular vein, here's your carotid, which is what we just saw. And then there's like the SCM muscle. Then later on, once you have you've found the vessel, you've punctured it, you have your flashback, you've unhooked your syringe, and you have inserted your guide wire. You want to make sure that you're in the right place, and so you just flip your probe longitudinally up and down, and then you see this view, and you can see there's your guide wire right here. And in this situation, you keep the probe marker to the patient's head, which is similar to all ultrasound, right? And then we kind of already talked about this, but your vein is thin-walled and compressible, and then your artery is thick-walled and non-compressible. You want to make sure there's no DVT prior to placement, so they push compression, and this vein collapses nicely, so you know that's an okay target. Here's some examples. This is your femoral artery, femoral vein, femoral nerve. Here's your jugular, your carotid. And then this nasty devil down here that you all love is your subclavian, okay? So hopefully stop using subclavian as much because here's your subclavian vein, and look right here, that's your pleural line. So if you back wall your subclavian central line, you are going to cause a pneumo, or you're going to puncture their lung. And it, not only that, but we all agree that ultrasound is much better. Like, all the data shows ultrasound guided lines much better than not using ultrasound. And using ultrasound on subclavian is pretty hard because you have your ribs and your clavicle, and just the anatomy is really difficult. So try to not do this anymore, okay? Try to use femoral or jugular. Okay, Di?
No. We must do it very quickly. The trauma patient is going dead very quickly, so I put the CC.
Femoral. Do femoral. You can do femoral.
Here's
just
only
quick.
2 minutes. Do it very quickly.
All right, Di.
We try it when you have a shock, you like something like you have a hypertension with the septic or something, and you pray everything for 10 minutes and you slowly put the central line on. But when you have a trauma patient, it's very
Okay, that's
quickly.
fair.
Yeah.
We can compromise. Okay.
All right.
All right, it's fine. Just for now. And then once you get good at this, then we'll talk again.
All right.
Okay. All right, so pro tips. I already talked about this when we were looking at Scott's anatomy, but move the probe to find the best location before you puncture. So this is not really ideal because it's, you know, up and down. They're on top of each other. So move until you find something like this where you can back wall that vein and you are not going to cause any problems. And then another pro tip is that you can use a center line, which makes it so much easier, especially when you first are starting out. So imagine, like, this is your probe. This is your probe marker on your left, right? If you're like holding it like this, you're above the person's head. And then you see this center line on the ultrasound probe, and then you can push either on your ultrasound machine. You can either click in mode, or sometimes ultrasound machines have a button that says center line. So click one of those, and then this nice, beautiful center line pops up on your screen. And you know if you are puncturing the skin right at that center line of your probe, it's going to perfectly match up to that center line on the screen. Okay. All right, so we talked about all the concepts, so now we are ready to go, right? You have your patient in position, all the stuff ready, and you're going to have the probe in the transverse view, the probe marker to your left, if we're doing, or no matter what, probe marker to your left. Then you're gonna, let's see here. So this is what I see. Let's start at this picture, okay? So this is jugular vein, this is carotid. We found our good spot where they're not up and down on top of each other. We're gonna compress, make sure it compresses. There's no DVT there. We're gonna use our lidocaine like usual, and you can do that with ultrasound, but you don't have to, but you can like inject, you know, superficially or whatever. Then once you're like ready to go, you're ready to stick, this is what you're gonna see. So first you're gonna insert your needle into the skin like normal, and you'll see this like bright white dot pop up, and this is your target down here. And you're just gonna keep inserting your needle like normal with your negative pressure applied. You might see this where the vessel wall starts to tent inwards, and that's how you know you're about to puncture through the vessel. You can also feel it because we're all used to doing it blind, right? So you can feel this very easily. Then once you actually pop through, you'll see the needle tip inside the vessel. And again, while you're holding negative pressure, so your syringe will be filling with blood, you know that you're in. Once you get to this spot and you have your syringe filled with blood, put your probe down, okay? Like put it down, and that, because you need two hands. Just like normal, you're gonna unhook your syringe from your needle, and then you're gonna take your guide wire and you're gonna thread your guide wire in your needle just like normal. Again, you don't have ultrasound right now. You're gonna take the needle out and your guide wire's in there. Now you're gonna pick your ultrasound probe up again, and you're gonna put it in longitudinal view, so the probe marker up to their head. And this is what you're gonna see. You're gonna see that your guide wire it's beautiful, it's going in the vessel. So you know that you are in there. You can even like pull this back and forth, back and forth, back and forth, and see that it's like moving inside the blood vessel. So that's how we confirm. This view is extremely helpful also for troubleshooting. So sometimes, I'm sure we've done central lines where you get initial flashback of blood, and then you like go to thread your wire and the wire is hitting resistance and you can't thread it, right? So you can use this view and you can like move your guide wire back and forth, and you might see that your guide wire is actually down here. So it's punctured through the back of the vessel, and then you can dynamically pull the guide wire back, and you see it pull back, pull back, pull back, and then all of a sudden you'll see it in the vessel again, and then you can push it forward, and it works. Okay, so this is super, super helpful to troubleshoot. And then, yeah, so you can watch, make sure it's not through the posterior wall, and then after you're all done, you can use the ultrasound again to slide down and look for a pneumothorax. And then, yeah.
Although if you're doing IJ, or the internal jugular, the risk of causing a pneumothorax is almost zero.
Right.
So during this procedure, I find it's quite difficult to follow the tips of the needle. You know.
You find it difficult, you said?
Yeah, to follow the tip of the needle. Sometimes you lose the sight of the tip of the needle. You just see the needle, but it's not the tip. So you cannot watch it piercing the jugular vein. So.
Yes, you're right. So that is why I think this picture right here, this is so helpful, because what I think is like the best way to learn this initially is to find your location and plant your probe, like plant your hand in this one spot with your center line lined up, and then take your needle and insert it into the skin, and do not move your ultrasound probe. And push your needle until you see that you'll see this. Even if you don't ever see this needle tip, you should see this. As long as it's like in the right spot, your center line's there, everything's lined up, you'll see the tent. And then you just like push it further and you feel the pop and you get the flashback. But you're right, that sometimes you do not see the needle tip. But I think this is like you'll have that every time.
And so do you think it is easier when you do it with longitudinal plane? Well, when you put a needle in, and with longitudinal plane, you can see the tip needle that go forward.
So I think that if someone is really good at that, then like certainly it might be, maybe that's just like how they learned it and they're really good at it or something. But I think it's really hard to make sure that you're lined up correctly. Because like you could have, say you have this view or something, and then you puncture your needle, like you don't know if the needle is perfectly lined up on the center of the vessel, like it could be coming in at the side or something. So I don't think that's, what do you think? I don't think that's...
I think there's more than one way to do it.
Yeah, for sure.
I think that the classic way is the way Shirley's teaching it. And I think this is like if you can't get it the way Shirley's teaching it, this is something you could try at plan B, is to try it longitudinal. And plan A is you watch the needle go in real easy and you can follow it perfectly in. But sometimes that's not exactly going to happen, but you can at least know that you're seeing the vein tent, right before you pop in. Or you at least know that you've lined up and you found the anatomy that's safe, that you know that you can just advance this needle and that you're never going to hit the carotid artery. So if you get blood, even if you don't necessarily see the needle go in, you know that you are in the right location. So it's kind of like there's an ideal world, and then there's like nothing's going quite right. But even in those situations, ultrasound is still super helpful because you know